the building is on fire, and we believe as quickly as we can go to the front door. The toilets, for those of you that are interested, is just in the lobby of the building. The presentations that you're going to see will all be circulated by Carolyn over the next couple of days. The presentations are being videoed as well at the moment. If anybody's worried about that, if there's any issues about that, then please speak to Carolyn about it. And also, if you could complete the evaluation forms at the end, that would be really appreciated as well. So thank you very much. So as you can see, we've got a full list of really interesting presentations, quite varied presentations from clinicians and third-party providers about the local services that are available. I'm not going to speak for very long at all. The only thing that I wanted to tell you very briefly is about a treatment-resistant depression clinic that we run in the Warrenford Hospital. This is a research-focused clinic, and we are staffed by psychiatrists. We run studies of people with treatment-resistant depression. Most of the studies are pharmacological studies, although there are some cognitive studies in the pipeline that are coming along. And if you have patients who you think have treatment-resistant depression, so that's very broadly defined, just somebody that has tried a couple of different treatments and they have symptoms that are still impairing their functioning to some degree, and that person's willing to consider being involved in research. You don't have to agree, obviously, just willing to think about it, then please do send them along to us, and you can just email a referral to the Oxford Health Clinic or send a letter to us in the Warrenford Hospital. And it's the sorts of things that we do quite well, I think, are we give advice and management on the sort of quite common situation where somebody's really not responded to the first-line treatments of medication, and we can give advice about what might be like a reasonable thing to try, particularly from the point of view of pharmacology, and also for those people that are enrolled in trials, we can give ongoing support and management for them as well. And so there's quite a lot of trials that are ongoing at the moment of different treatments for treatment-resistant depression. There's a list of them here, but these change all the time. And so particularly for people, not necessarily complex people, but just the quite common situation where somebody's come along, you've tried a couple of SSRIs or venlafaxine or whatever it might be, and it's just not worked and not worked well enough. Please do think of referring them to us. So that's all I had to say about myself. So the next thing I'm going to do is introduce our next speaker, who's Judith Chapman, Clinical Director at Berkshire NHS Foundation Trust. And Judith's going to tell us about IAPT for long-term conditions.
Hi, thank you so much. Hi, nice to be here. Hello everyone, hope you're all well. I got very lost in Green Park, I hope you didn't. Obviously, not psychological therapists aren't good at finding their way. Anyway, I know quite a lot of you, so thanks for inviting me to speak. I think I've got quite a broad set of slides to go through, and it's really difficult to guide what you don't know, and hit that spot that might be helpful for you. I'm also thinking I've got a couple of, well actually more than a couple of people of experts here on the subject I'm talking on, and Inika at the back is our HSN lead when it comes to me discussing one of the research projects we've been doing in the HSN. She might be able to answer your questions better than me. But my background is in physical health. I'm a nurse and a health visitor. I then joined when the IAPT program got set up, that's the Improving Access to Psychological Therapies. I then joined the Trust and Berkshire 10 years ago, and that was after I'd done psychological training, and I'm just so excited that finally we are thinking of people as a holistic person and looking at integrating physical health and mental health. And obviously, as you heard Angus talking about bringing in physical health checks, as we know, for people with mental health problems, really my subject today is about bringing in psychological treatments for people with physical health problems, so that actually we're mapping it across. So first of all, I'm going to just mention the size of the problem, then I'm going to tell you a little bit about what we did, and move quite swiftly into some of our evaluation and cost-saving analysis. We have been very fortunate in Berkshire to be ahead in looking at how we treat people with anxiety, depression and diabetes, or medically unexplained symptoms, way back when we got some project funding in 2010.
And that really has helped us to set things on the road. And if any of you know Nick Buchanan, as the Commissioner, he was really innovative in helping us get set up. So this really is just showing the number of people who have a problem in integrating their care, a psychological and mental health problem, with people who have a long-term condition. And approximately every other person will have some sort of low mood or anxiety that could be supported by a psychological intervention. And I was really excited. Some of you might know I work in diabetes, but when we actually delivered psychological interventions, low-level group psychological interventions for people who had low mood and diabetes, and this is way back 2012-13, we were also able to look at quite a sample of patients and their HbA1c blood tests, and we were able to get the hard evidence that helping people to feel better means they manage their healthcare, less cost, less time spent in the health system. So this is all about behavioural management. And I think it is just so important to think that actually through the latest evidence-based therapies like CBT, people will change and they will be able to affect their behaviours that mean their management. So things like their self-care, of their foot care, attending for appointments, managing their diet. It was really, and if any of you are interested, I can certainly send you that piece of work that was published. But that really, for me, was, you know, it was just so amazing that we could have the evidence that how treating somebody's mental health will really improve their physical health. So just talking about the numbers here, but I thought you can have the slide set and look at the details. And so we know that untreated comorbid problems will increase the cost and use of services in Berkshire by 25%. And there's just some estimate, and approximately it is determined by the King's Fund. It's £1,760 per patient if we don't treat their anxiety and depression. So a lot of you might be aware of the 5-year forward view target that IAPT services will expand. We obviously know ours as Talking Therapies. You know, we're so good at abbreviations, but we're Talking Therapies, and that's about increasing the access on the prevalence of anxiety and depression to 25%. So the denominator of depression in Berkshire is round about 92,000, 93,000. That is the old census, which is very dated, and it has increased. I don't know what it's increased to, but approximately we need to treat by 2021, which is kind of almost next year, isn't it? That will take us up to nearly 24,000 patients a year. So it is quite a, you know, it's a primary care service. We offer low-level interventions and step people up if they need formal psychology or CBT, but that is amazing. So really we are assessing about 380 patients a week to have that access level. It's quite a machine, but I kind of think having, you know, being responsible for taxpayers' money, I think it's really good that we are offering the lowest intervention first. We're easily to access. We will offer people more if they need to, but we're very evidence-based around NICE. All our therapists are trained according to the evidence, and we will help people to recover. So we've got a whole load of rich data on outcomes. There's a lot of detail in some of the slides, so there's just a principle here, a nice guidance if you want to read it later. Sorry, that filled up quickly. But I did print a few out for you, but what is an IAPT LTC service? So the IAPT service is here to treat people with low anxiety and depression, and the IAPT LTC is to be effective for people where we're focusing on those integrating our care for people with a physical health problem. And we currently are treating around about 23% of people that we treat in IAPT have a physical health problem. And our aim is by 2021 to increase that to 30%, because we know the effectiveness on relieving their distressing symptoms and getting their lives back, but also the fact that they will then increase their self-care and reduce the burden on the health service. So when I say long-term conditions, we're particularly focusing in Berkshire on diabetes, MUS, medically unexplained symptoms, or persistent physical symptoms. we try to move to that, but we keep coming back in all the journals and manuals, it says MUS. And we've got quite a lot of experience with that in working with liaison psychiatry. Those of you might know Abra Hussain, but we've got a joined up pathway, which is very helpful to try and help people who just repeatedly going around with no obvious diagnosis. And so we're looking at COPD, diabetes, and heart conditions. But since we started the project in 2016, which was from national funding, we actually have now found, now that we've really gone live, we try to treat anybody's physical health problem. But of course, we're not treating the physical health problem, we're treating the anxiety and depression, and we're trying to understand how their diagnosis of diabetes or COPD might mean that the examples that we share with them and how we try and encourage them will be around their condition. So all our therapists who are treating the long-term condition, anxiety and depression, comorbid, have had some top-up CPD training. We also are working with the respiratory pathway, with the diabetes pathway, and so actually having some physical health training we're now getting at from our colleagues, and then we're trying to help our physical health colleagues to identify. So very much moving to joint pathways. There's a lot of data around how we need to join up physical health and mental health. And so a lot of you might not know, but these are all the conditions that we treat in IAPT. And sometimes as GPs, you might not be aware that we treat those things, so specific phobias. If somebody's got a fear of heights and it's really impacting their lives, or if somebody's got a fear of flying, those components we would really treat. Health anxiety. I know this is something that Angus and I really talked about, is that we think there's a lot of people that you're seeing that actually it's because there is no, obviously we've got Google, but actually if you pick up somebody who you feel is very anxious, please refer them to us, because we have got treatment protocols and we will actually help together, and this is where it would be really helpful to co-work with you so that actually you could stop perhaps going off for investigations and things whilst they were having their treatment. Obsessive compulsive disorder, that's prevalent in around 5% of our referrals, but it's undetected around about 2%. So again, people whose lives are excessively checking, washing, things that might come up, then really please do refer them to us. I mean, panic disorder and depression, yes, that's bread and butter for talking therapies, but there's a lot of other things. So the things that we're also interested in, irritable bowel, medically unexplained symptoms. We know you've got your own chronic pain pathway, but looking at how we co-work with that is something we want to develop in the future. So in IAPT, we capture the benefits. So we do a minimum data set. Everybody who comes to us, we do outcomes every time we see them. We're also collecting long-term condition-specific disorder measures. So that would be to identify how their symptoms are, and there's one for all the physical health problems that we treat. We also measure something called WASAS, which is disability, and that is work and social adjustment. So it helps to find out, are their lives restricted by their mental health problem, and then we look to measure to see that actually the therapy has helped and for it to reduce. And the other measure is a CSRI, which is a client service inventory, which measures the amount of treatment, the times they've gone to see their GP, and also we measure patient experience. So these are the things that we have measured consistently with patients with long-term conditions since 2016 to try and find out how we can be effective. That just shows you the conditions that are recommended, which are diabetes, COPD, heart disease, chronic pain. We're not doing that yet specifically as a pathway, but we will try and help people, ME, IBS, and persistent physical symptoms. So really this is just a little picture of what we've done so far. And I'm not sure how important it is to you, because I think it's just important to know actually we're there. We're trying to be in every pathway. And we've now got about 20 therapists integrated with GP practices, and some of you might actually have one of the therapists there. I know that obviously we're in yours, and I'm just kind of looking around thinking where else might we be. And we've been particularly trying to target health anxiety and frequent attenders. And in the work that comes out from the AHSN, where we've done a wedge study with Oxford University, it is interesting that actually that's where some of the highest cost savings have been, by actually having a psychological intervention for people who have a long-term condition, but they're frequently attending and they're suffering with anxiety. So perhaps you could start to think about people that you could refer, because we'd love more referrals, and I've got some really easy little prompts for you to give you. The whole idea is really to integrate increased self-care, peer support. So in the east of the county, we've got health makers, we've got psychological interventions in nursing and the community. The other thing that we really just launched is CBT for insomnia. So, and I know we've written out to you as GPs in our newsletters, and that's, I think, always difficult because a newsletter is hard to hit your spot. But we are very much hoping we'll be on DXS in a couple of months, and that would really help you to understand, and that would point you towards treating and talking therapies. Because with reaching this new access target that we've got to find different cohorts of patients. It feels to me, having been doing this for now 10 years, although it's surprising how many referrals still keep coming, and we do know that I think probably with some of the issues in the West, in Reading at the moment, we seem to have a lot more referrals from Reading coming to us. But with working with the CPE model that was just shared at the beginning of the Wellbeing Service, we're really hoping that we'll be just one pathway, and that we really will be able to pick people up who need a long-term condition, have got a long-term condition support, or can actually have a mild treatment in IAPT. But we really do need more referrals. We need to think about the people that you might not be thinking about with a physical health problem. And they only need to answer one of these questions. During the last month, have you been nervous, anxious, or on edge? Have you not been able to stop or control worrying? So those are the first two questions on the GAD-7, which is an outcome measure. Or been feeling down, depressed, or hopeless, or had little interest or pleasure in doing things. And what we're saying is, if anybody says yes to one of those, because how do you identify low mood? And what's been really interesting, it's the group of people who are in the very almost sub-threshold level that can make the greatest difference in their long-term conditions. Obviously, we've then got the other people who are quite complex, but there is a problem that on the frailty index, once they're extremely complex, we want to educate people. CBT is all about teaching people skills for life, to know how they can be their own manager and stay well. And on that point, I also ought to plug something called Paddle, which the AHSN has just developed, which is going to be an app that's going to help you to stay well. Okay, I don't want to just tell you stuff that you don't really need to know, but we've been busy setting things up. We've got a new pathway. We've tried to make it as easy as possible, so that I hope you can really easily either send people to talking therapists, they can self-refer, you can just quickly go online and send us their details. If they have got a long-term condition, it is really handy if we know anything that you think will be relevant to care. But we're really happy to just access them as they are face-to-face. But we do know that you would be the expert, so if there is anything we need to know, it's always great to just get even a one-liner. So the good news is that in our data we have maintained our recovery rate, which is obviously around the quality of the care. So we know that 57% of people in Berkshire will recover and be able to maintain staying well. And this is just the breakdown of how we've been treating patients. And we've actually now included, so as well as COPD, we're actually just calling it lung conditions. We're finding a lot of people with asthma, obviously the anxiety around that condition, and we can really help people and hopefully reduce their medication as well, just because they'll be less dependent on their inhalers. So we have been doing a wedge study and looking at matched pairs of client service inventory, and that is a way of them telling us how much treatment they've had from different services before and after they've had their psychological intervention. It sounds quite crude, it is, but it does give us a good indication of the client's perception And when we have now, this is where Inika probably could talk better about it, but when we've actually looked at the SUS data and historically findings, it matches quite well what the patients tell us on how much they've used services and how the SUS data relates. And this is the difficulty that we have. I know we've got connected care, but we aren't quite integrated, so we don't actually know really yet which groups of clients we should treat, and we haven't got our systems to actually map across. So that would be great if we could carry on that work. And I know that there are things in the system here that could help us. I think it's Eclipse, isn't it, that could really help us to look at that. So on the work that we did on just 108 patients before and after treatment, there was a 26% reduction in GP appointments, a 67% in ED attendances. So these would be people with anxiety, so COPD, breathlessness, panic attacks, reduction in ambulance calls, a reduction in X-rays, and 3-month savings approximately. And the difficulty is obviously this is in the system, so how do we affect that and how do we pull that out? So really the whole goal is we want to help you with your persistently difficult patients who have a long-term physical health problem. We want you to think if they present with, say, a health anxiety, or you think they're actually visiting the surgery more often. You know, it's a difficult one. How do you introduce talking therapies? But we're very happy to come and have a psychological training session. We deliver PIP care. We can help you with 10-minute CBT. We also have developed a package of coming to surgeries to meet the whole teams on helping the whole team to stay well, and offering some stress-less tips, and then actually discussing how to make a, you know, how to identify a psychological problem. Obviously some of you are absolute experts at this. That's just a little clip on how to refer, but you'll have the project with a slide. So this is just this little card we've developed. It's called the Woolly Questions, so that you can ask your patients. We've had a lot of key learning. We know the key thing is it seems to take time. The greater we can have dialogue with you, the better. We also, you know, are facing the same challenges as a lot of you in funding. At the moment in the West, if you look at the 5-year forward view plan to meet that new access target, and I think this is a really good audience to mention it, we have 23 vacancies short that we've been seeking from the West CCG, and as you know, the system hasn't got the money. And in the East, we've had some really exciting funding last year, and next year we will still have a vacancy gap of about 10 therapists. So that's a challenge, and obviously we are still begging for money because it means we can reach more people. But I think what it will mean is that we will need to offer low-level online therapy or courses of therapy to help people. So, you know, we will still have enough resource to move those into step 3 or the moderate end of our, to severe end of our service. But I think we do need you to understand that if we don't get that funding, lots of people will have a lower intervention first and then move through. But we are looking at some very exciting ways of helping people whilst they're on waiting lists, and that's the other problem, is waiting lists. We aim to treat everyone and start treatment within 6 weeks in Berkshire, which is really good, and we have managed to keep to that, apart from in Reading at the moment. It's been gradually going from 8 to 10 weeks, 10 to 12 weeks, and currently it is at 14 weeks. But we are looking at what we can offer those people whilst they're waiting. But of course, and I think that's where it could help us, if you were able to say to people, you might get offered a group that would be fantastic to help you in the first place, and please go to that group, because it will then start on their journey to learn some skills. And also things like, don't forget the client group with insomnia, that we really want those referrals. Anyway, we feel we've been joining things up with patients. We've just really got going. And now I just want to quickly mention how we're doing on the Thames Valley Early Implementer outcome and the health economic analysis that we're doing. So we've just got some results from cohort 1 that have looked very promising. We really are just looking at cohort 2, but this was to really analyse does psychological therapy provided by the IAPT LTC programme reduce healthcare utilisation and associated healthcare cost? And so we've been working with Oxfordshire and Buckinghamshire, and we've only got the results on cohort 1. I'm feeling a little bit that you might have more to say, Inika, than me, but this is your beautiful diagram here on how we actually have phased a wedge study with help from Professor David Strickler in Oxford, and we tried to make a really robust study, and it's ongoing, but this has involved analysing the SUS data. And we've got some really promising clinical outcomes from the group, that the recovery rate, the average was 56.9% overall. We had a reliable improvement rate where everybody improved by, it's between 5 and 6 points on one of the outcome measures. So on a PHQ-9 they dropped by 4.5, and on a GAD-7 there was a change of 4.1. And 2 or more people, 72% had 2 or more sessions. And if they would stay the course, I mean, that's the other thing to try and help us with your patients, is when they drop out, it's because it's difficult. You know, obviously these people have had avoidant lives to be able to stay coping. So with CBT, if you know, we are actually challenging those thoughts and trying to get them to do social experiments and behavioural experiments that will actually challenge that and help them to realise they can still stay alive and put themselves in a panicky situation with their friend, report back to us. But of course, once we start asking to do those behavioural experiments, it does get really tough. And so although we will talk people through it and coach them and try and be obviously very sensitive so that we're doing it in a measured way, it can be quite a challenge, so people drop out. And we know that our recovery rate if people stay the course of treatment is around 90%. So it's just the dropout that really affects us. And if they stay the course and they really need it, they can have up to 20 sessions. What we're trying to do is obviously treat people with the lowest level wherever we can, but we're also trying to help them not to relapse. And the goal with CBT is that actually top-up sessions would help them to stay well really easily. So just to look at the health economics finding, we looked at 3 months before, pre-IAPT, and 3 months post-IAPT. And this just highlights the saving on the whole cohort, which was 462 patients. And by joining together across Thames Valley, that has given us a sizable cohort. And the saving in primary care was approximately £117, secondary care was 212, and that was just over that 3-month period. So for patients who go through the whole of the IAPT treatment programme, on average, after treatment costs have been taken into account, and on our estimation that the treatment is recognised will last 26 months, and after we've taken treatment costs away, the benefit is £110 per month over 17 months. And the saving is £1,870 per patient, which is really good. So we know it's effective, we know patients get better, and we know it's worthwhile. Is there anything you want to say, Inika, about the further findings or anything about the work to date? But we really have analysed it, we're confident it's robust, and we are wanting to obviously increase our offering for the right patients, and perhaps look at your local data and work with you more to increase that. And when we can get our full funding, obviously to make sure that every surgery has got somebody with an integrated IAPT LTC worker, at least working in your surgery, offering 1 day of psychological interventions, because we feel the setting is right if they're coming to you for the physical care. And we actually went through a whole load of campaigning to work out what should we call our therapists, and we came up with health coaches. And that was really to try to get over the barrier and the stigma to get people to come into treatment who've got a physical health problem. What, you think I need to see a shrink? You know, and thinking through about, talking to them about, well, actually, if you've got some tips to how you can stay well through understanding the things that perhaps cause you distress, and look at how you can increase your well-being, we know that your health will stay better. And having that conversation so that actually it's about a qualified therapist. So we are going to change the name back to Talking Health Therapists, just because we know there's a lot of health coaches or coaches out there who aren't qualified, whereas all our therapists are often nurses, OTs, or psychologists who've done further CBT training and now have done LTC top-up. So we really know these are our best therapists, and especially dealing with mentally unexplained symptoms, that is really complex. And the goal we'd really like to be is part of your MDT, so that we could have a conversation with you about how to handle difficult clients, how we could work together, how we could feel very much we were working with you, and that there was that quick access for that dialogue. And because although we've got a really robust system of easy referrals into talking therapies and how we assess them and how we move the flow so we don't have any waste in our system, I still think there's a lot that we could do, which is to just make sure we're back into conversation with you. I think that's a quick summary of where we're at, but there's lots more to do. Thank you. Any questions? Okay.
I'm very interested in your outcomes data showing the effectiveness of your interventions. And connected care, I've seen demonstrations, but it's not up and running yet, but it will be a very powerful piece of software that will be able to tell us the effect, this kind of data we want, i.e. the effectiveness of an intervention. But what's occurring to me is that at the moment, certainly not in my practice, we're not actually coding referral to IAPT, and we're not coding attendance at IAPT. And I don't know if some practices are doing that, but if we're not doing that, it's not going to be possible for connected care to give us that information.
And I think this is where, because we're not you, I think this is actually how we need to think through how can we problem solve the dilemmas to make sure we can make it fit for purpose and robust. Because I can understand that if you can't code it, then you don't know, and only we know. But one thing we could do is obviously easily give you a monthly list of the people we're seeing if you didn't know, apart from obviously writing a letter, because, well, obviously, or an email or on DXS. But if we could find a way that you knew so that it did count, because this has been, I can assure you, a labour of love, asking clients before they start IAPT, when they end IAPT, and 3 months after, you were talking about 20 questions, and we do a PHQ-9, and we do a GAD-7, and we do a disorder specific. When we've got this in the system somehow, but of course the permissions to share data has overcome us, and if we could get into this connected care, are you on the steering group or whatever?
No, but I've seen a couple of demonstrations on it. It looks pretty impressive actually.
Yeah.
But I don't know how we get GPs coding these things, because the problem is, I'm a GP, and I'm always trying to get GPs to code things, and I think unfortunately we're all kind of overloading the GPs with what we want them to do, basically. So
because I know,
it's quite a challenge, I think. But I don't know, Angus, do you code it in your practice?
So not on as the individual letters come back from Talking Therapies, but there is you can add a bulk code. We've been looking at this for dementia coding for expert attendance as well. A bulk coding, so a spreadsheet, like say monthly or quarterly spreadsheet, and there is, most GP systems can bulk add those codes. So that is something that's technically possible. The permissions and so on need to be agreed and between practices to say that you're willing to accept those codes. But that would be a way, that would be a nice, easy, non-clinical time solution to doing that.
Well, perhaps we could even pilot, just try and work on something with
it. Yeah, I mean, and
or,
if you're entering on Rio, that should link into Connected Care
yes,
anyway.
but we're on
but
IAPT,
you're on
which
IAPT,
is a different system.
so it would have to be through either Rio or a GP system. But it's certainly possible.
Yeah, it would, that would be where it'd be really good.
Yeah.
So that actually we could also do some targeted referrals.
Yeah.
You've got the evidence.
Yeah.
Some patients do self-referral.
Well, everybody can self-refer, So they do. But of course the difficulty is we might not be getting the patients that you really want us to see. Yeah.
I'm a huge supporter of what you do and refer frequently, but what I'm concerned about is you're asking for more and more referrals, and I think these referrals would be completely appropriate. But you're also saying how much you're understaffed, and I'm a central Reading GP, and you say your waiting list has gone up to 14 weeks. So I'm really worried about.
Well, that is for people who need the second level of intervention, which is why I'm saying if everybody would accept our first offer, because we can offer stressless, we can offer online CBT, and then still keep them on the waiting list. But they often are just waiting for the face-to-face therapy. But I'm as despondent as you, because we really were offering everybody 6 weeks, but our access in Reading has hit the target of 2020 without the extra funding. So it is a dilemma for us, and you know, Angus, we've been petitioning strongly for the funding.
The people to ask are the commissioners, so ask me through your GP councils, drum up that exactly what you've captured there. This is a really useful, proven intervention. It's helping people through your GP councils. Get it on the agendas. Get it known at the commissioning level that this is something that GPs feel is benefiting patients and want, and we can steal a march on. Basically, I also work at the CCG, and I've been trying to make that case through the robust academic evaluation. It should be a given, but in these financial times, etc., etc. But grassroots, absolutely, yeah.
So we used to have a night counsellor in the surgery. For some reason we lost it, and we feel it's a huge loss. How do we go about re-establishing?
Are you
the same with us also?
Emma Green, where are you?
Tarhurst.
Well, we can certainly, one of the problems has been where we have been removed in lots of areas because people have had paramedics, so there hasn't been space, or there's been a secondary charge, and that is difficult for us if there's high costs involved in charging for the room, because it's about we're funded through the CCG and then it's a double funding. And so we were told that we had to come out of surgeries that would charge us.
And just to clarify, for any partners in the room, if you're charging another NHS institution like BHFT, you will get rent abated for the exact same amount, so don't charge because it's just circular money. So you'll get pseudo income from charging the room rent, but that income will be taken off your notional rent because you're charging another NHS organisation. So not everyone's aware of that, but actually, unless that's private property that's not NHS GMS footprint, so you might have an extension that you own yourselves and you're renting that out, that's different. But if it's in your GMS footprint that the CCG is giving you notional rent for, and you're then subcontracting that room out, it's all going to go around in a big circle. So it's a lot of paperwork and not worth it.
What about cost rent?
I think we've taken time for one more question.
So you're at Tarhurst, and so where are you?
It's not necessarily surgery. Our counsellor retired, and then it was more than a year ago, and never been replaced. And we are on cost rent.
I'm afraid it's the same issue for cost.
Sorry, with due respect, I don't think
issue.
that's relevant.
You can't change.
The rent and reimbursement not relevant to this particular course. I'm afraid to say that, we all know that you can charge electricity and gas, not that's all you can charge about intervention. That's not an issue. This is a long time coming, the intervention of psychological sort of support in long-term conditions, and as you quite clearly shown the benefit, 57%. There are 3 issues that I have. The first big issue is, how are you going to raise the awareness for the patients with long-term conditions? Because historically, they are sort of ingrained in their brain, pill for every ill, first thing, yeah? And second, how are you going to raise the awareness at the secondary care level? Because that's where also the patients need to be told, we've done what we can do at the secondary care, you need to have this intervention. That's the second thing. And thirdly, a sizable population who do not speak English, who are not very literate with your IT systems, which is what you're providing at the moment. How are you going to tackle those particular population? And I especially have in mind Asian population, whose sort of psychological always says there is treatment for every illness. Do you follow me? So these are the people who need to target it by some other way rather than your IT systems.
Yes, and obviously they don't always come to courses or groups. I mean, we have been doing some sort of drop-in sessions for Asians, and we did do some diabetic groups for Asians in Asian languages. And we unfortunately have been, well, we've been working really closely with mother tongue, so we have got good cultural awareness in the team, but we have great difficulty with the interpreter system, and I don't think that's the answer. But I hear what you say. I mean, the awareness, well, I think, we could go on forever, but obviously the whole idea of helping people to self-manage, that's why at early diagnosis it'd be great if we could have a psychological intervention, so that actually part of the diabetic pathway for those who are diagnosed, we just become part of. Like you see the chiropodist, you have your eyes checked, you have a well-being discussion. Yeah. Okay. Thank you ever so much.
Thank you very much.
Yeah.